Okay, and we'll go ahead and get started. So I'm delighted to welcome everyone, whether you're Zooming in and it's morning for you or afternoon or evening. Thank you so much for taking the time to join us. I'm delighted to, first of all, my name is Dr. Amy Sapkota, and I'm leading our Global FEWture Alliance, our new group of multidisciplinary international collaborators that are working together to alleviate food, energy, and water insecurity and protect and promote environmental and global public health. Today, we are delighted to have Dr. Biraj Karmacharya as our speaker. Dr. Karmacharya is the Director of Public Health and Community Programs and Global Engagement at Dhulikhel Hospital in Nepal. He's also an associate professor at the Department of Public Health and at Kathmandu University School of Medical Sciences. He obtained his MBBS from Kathmandu University, his MS from Mahidol University in Thailand, and his PhD in epidemiology as a Fulbright Science and Technology awardee, and his MPH in global health, both from the University of Washington in Seattle. He was also the founding co-director of Nepal Studies Initiative at the Jackson School of International Studies at the University of Washington. He founded and has been leading the Department of Community Programs and Public Health at Dhulikhel Hospital since 2006, through which he's engaged in developing and setting up innovative community-based health and integrated health and development programs in Nepal. He has also been instrumental in advancing public health training and research in Nepal, leading the pioneering programs, the Masters of Science in Public Health in Epidemiology and Public Health and Global Health, and most recently, a new PhD program in Public Health at Kathmandu University. His research interests span across non-communicable diseases, climate change, and health systems and policies. And we are delighted that he will be speaking with us today about an integrated approach to rural health and community development through livelihood support, an experience of Dhulikhel Hospital. So thank you so much, Biraj. I'm going to go ahead and stop sharing, and you can go ahead and share your screen.
Yeah, thank you, Amy. Let me just share my screen. So is it visible now?
Yeah, looks great.
Okay, so hello everyone from Nepal. This is Biraj from Dhulikhel, and I'd like to show this picture in the beginning of my presentation. Actually, this is the town where I work, and within a couple of weeks, we'll have a view like this of the mountains. And right out at the outset of presentation, and I'd just like to give the disclaimer. By no means I'm an expert in terms of this integrated approach to health and development. I'm just going to share some of my own professional stories, some of the mistakes that we have made, some of the successes that we have gained, and how we have evolved over the course of time. So I think it is important to give a very brief background of the institution, Dhulikhel Hospital, because it is a little bit different than most of the hospitals that we imagine. So this was a piece of land that was donated by the community of Dhulikhel to build a hospital 27 years ago. And it was the first community-based hospital in Nepal. So the modality of the institution was very different. It is deeply embedded within the community, not just in terms of infrastructure, but also in terms of governance. Even now, the highest board of the hospital comprises of representatives from the local community, the social workers, mayor, and so on. So this was a new experiment 27 years ago, and it had a very modest beginning. It started as a small 25-bedded hospital, then with a vision of quality health care to the poor. We now call it quality health service to all, but it started with this vision of quality health care to the poor. So, reaching out to the unreached and making healthcare accessible to the most vulnerable population in the region was its main goal, right from the very beginning. But when it started, it became one of the fastest growing institutions in the country. And fast forward that to 20 years, and we have it's a huge complex now, and you can see all the growth that has happened in the area just in last 27 years. It completely transformed the whole locality. Currently, it's a fully functioning tertiary level university hospital with almost 500 beds and serving almost around 2,000 plus patients every day. So that has been an interesting story of the institution. But another very interesting part is even when the hospital was starting in the early years, the founders thought that a huge majority of the population whom the institution is supposed to serve might not be able to reach to this central hospital. So even then, they conceived this idea of building outreach centers, which are like the small satellite hospitals in different rural regions of the country. And that was how the whole concept of outreach centers started. And we assembled the whole program of the outreach centers and others into what we call the Department of Community Programs, which we founded in 2006. And when we, drafted this vision in 2007, 8, one thing, retrospectively thinking, I realized that we were very, very conscious about making sure that this is not entirely, an exercise related to health only. Because very early on, we started to realize that if we really want to make an impact on health in communities, then health care is only one of the small factors. There are lots of other factors that impact health, and we collectively put it under the terms community development. And this was how we framed our vision statement, a long time back. And so now we have 18 centers in different parts of the country, which are like the satellite centers of the hospital where we start these programs. We have about 250 staff, almost 150,000 plus patients are served through this, through the network of these 18 centers. And we have a range of programs, so not just health services, but also a lot of preventive programs, community development programs, academic programs, and so on. So today I'm going to focus primarily around the community development program. So this is how a typical outreach center looks like. Generally, these are we have about 5 to 7 staffs in each of the centers, and these provide round-the-clock services, health services to the community. But we have designed and launched these centers with the concept of a community center. So all the outreach centers are built not just as a health facility, but also as a community center where we organize community events. So, we organize teachers trainings, farmers trainings, we organize meetings of the women's groups, a youth group, and so on in all of these centers. So that has been a very different approach, at least in our setting, in terms of primary health care. So one of the first experiments that we started was the microfinance part. It was around 2007, and what we did was we were running this rural women's health program. Gathering women and taking classes about pregnancy, vaccination, sanitation, hygiene, and so on. And we started to realize that from our eyes as health professionals, health is the first priority. But from the eyes of the communities, it is the livelihood. They wouldn't be bothered to continue coming to the sessions on health if they have difficulty in fulfilling their basic needs. Number one, and number two, what we realized was that as individual women, they had a lot of knowledge already, but they did not have a collective voice that they could use in the communities. So what we thought was that if we could figure out a mechanism where we could get these women together, give them a collective voice, and help support livelihood, then these women's groups would be sort of charged women who would be the messengers of health in our communities. And that was how we designed our microfinance program. So it was, although it was a community empowerment program, it was, the hidden mission behind that was to propagate the health agenda. So that was how we started, and we would arrange organize women in a group of 10 to 15, and these women are the most vulnerable women in the communities. They would be selected with local community members. we started with a loan of at that time around like $60 or something, which they would pay back within about 2 years. And the condition was that they would meet at the health center every month. And during that month, they would during the meeting they would discuss about how many chicken they bought, how many they sold, how many pigs they have sold, and so on. And after each of these meetings, then we would organize health related trainings. So what happened was, after about 6 7 months, we would see that these women are now in groups. They are they have their own income sources. They don't need to ask their husbands for basic supplies. And because they are informed about health through the health programs at the outreach centers, they served as best messengers. And we have actually done some studies and published around that as well, how these women were mobilized for like cervical cancer screening programs, diabetes screening programs, and so on. So these are the pictures, how we have arranged these women. And the program that started with a couple of $100, and now it's a pretty large program with almost 2,000 plus women within our network. And it's really fascinating to see the growth of these women, like how they started as a shy, timid woman to a very, powerful leaders in the local communities. And you can see the lady in the blue is one of our staffs, who is doing this home visit. And these are the beneficiaries. The women at the right are the beneficiaries. So this is another, example of how we have these women. You can see in a small cot there's a child. So very often they come with their children. We also organize screening programs during this time. So this is how we do. So that was how we started our initial steps on community development and livelihood support. And then we started to get a little more daring, I would say. And this was another major venture where we really constructed a bridge to connect two villages, so that the villages from the other side of the river could get access to our health center. We also at that time supported and raised funds for 3 communities to build a whole water supply system in the village, because that was their primary demand. And we figured out that there was no sense of teaching about hand washing in the communities where they have shortage of water even to drink. Um, but the 2015, I don't know how many of you know, but in 2015, Nepal had a devastating earthquake. So that was, I would say, a turning point in our overall approach to livelihood support. The man that you see here, is one of the beneficiaries, where we heavily supported in the reconstruction of the damaged household. So we provided supplies to them and so on. But what we did was we sort of experimented with an approach, what we call the survival to revival project. Here we went to one community, about 200 households. My colleague Ruby, whom you can see here, at the center, who is a research assistant, then led this whole project with 200 families that were deeply impacted by the earthquake. And what we did then was create a program that incorporated agricultural training programs, support. And this was a community that had a big problem with water, and hence the agricultural production was very low. People were already very poor, and after the earthquake, like they were almost nowhere. So we provided them with microfinance funding, uh, trained them on newer agricultural techniques about vegetable farming and many others, supported them in building these small, plastic ponds at household levels, so that they could use and store the water from kitchen garden, from their kitchen, and use that. We use them from the field, and we were really um, amazed to see how the whole community flourished with this attempt. I will share a short video of this project if you are interested. You can have a look. It's a 10-minute video of the whole project, and of the testimonies of the participants as well. So this was another project that happened in 2016. You can see some of the pictures. So this was the first time we as a hospital hired an agricultural technician, and a community mobilizer. And it was almost unheard of in Nepal. And people would ask us, you're a hospital, like, why are you working in agriculture and why this? But our argument was that, it was, we felt very helpless, just being in the community with our, paramedic and medical staffs, when we could see very clearly that there were other things the communities needed. But what we did was, while we supported these communities on these livelihood programs, we also integrated the component of health. So we had a very strong component on women's health, elderly health, and also the school health program. So it was very, very well integrated and blended with the program, and they were very happy to participate and get benefited with those programs. So you can see, how we are training them to make these small tunnels, and these are some examples of the farming, some new ponds, farms in the local communities. And a nice anecdote here is, whenever we used to go there, for a couple of days of visits, we had to, in the past, we had to buy all vegetables and other products enough for our stay in the outreach center. But after this project, actually, when we returned, all of us, we used to buy and bring back a huge bunch of these fresh vegetables to our houses. And I was there in a meeting, and where the community said that, we now have a problem where we don't know, like, how to sell these vegetables, from the time when they did not have enough food to the time, they were saying, like, we have a problem with selling of these vegetables. So then, in collaboration with the local municipality, we started with collection centers in a small scale, because it's too expensive for each of these households to go to the city and sell. So these are some pictures, from the same project, and these are, some nice pumpkins. Not really good for Halloween, I'm sorry. And we also provided them with some very basic supplies. It was as a motivation for them. So this was like some materials and seeds and so on. And again, you can see these visits to the microfinance groups. And so this was, observation of some of our donors and partners to the households. We also linked that with other health-related programs. So this was a program where we supported in building improved cooking stove. This we call smokeless cooking stoves in the village. And this was the village where we declare for the first time, I think in Nepal, a smoke-free village, because all the households installed these improved cooking stoves that was made by local materials. We trained them, supported them nominally, and they managed to do it on their own. So after that, I would say we had no, way back. Then we started with other programs as well. In the bottom right, this is a picture of the fisheries project that we recently launched in one of our outreach centers. We are expanding it within a couple of months to a couple of other sites. This is I forgot the I forgot the exact technical term for this, but this is a fisheries project. In the left side, what you see here is a project that we supported in another community where the women gathered to run this loom and produce this indigenous clothes from the locality. So after that, so with this experience, then we managed to get a major funding from the Korean International Cooperation Agency. So then, so it was a very daring proposal for us and for the donors as well. So and it's entitled "Empowering Rural Communities in Nepal Through an Integrated Approach to Health and Income Growth." So this is currently undergoing in 3 sites. This is a basic description of the project. What you can see here is community development through integrated approach to health and income generation. These are the major goals. We have a major local community capacity building, income generation component, and the health component there. And it's all well laid out. And we are working with like major agricultural and community development partners in this. So this is a work on progress. So these are some of the components. I won't go through in detail about that, but the whole concept is same. The scale is at a larger level. These are the 3 different sites where we are running this project now. There's another example of recently launched this aloe vera plantation. We are starting with this, local level farming and production for basic cosmetic production center of our own hospital. So this is happening. So yeah, so these are just some stories, of our work. Uh, I would now I want to spend a few minutes about reflecting upon this. What has been a major challenges, which are also opportunities for us. Number one is building evidence. I have to confess that a lot of these programs started very much on a common sense basis. So we had um, so sort of trial and error method, and it was I have to confess that it was not a very well scientifically designed structured program. So we didn't really plan for research or rigorous data generation out of the program through which we could really see the long-term impacts. So we regret that, but at the same time we also realize that it was a very formative phase. So whatever we are going to do now, we're focusing a lot on a lot of data. So the work that we are currently doing in the 3 sites, we have extensive baseline data collection already done. We have household level data on health, livelihood, and we will keep track of how that will change over the course of time. So monitoring, evaluation, and data generation was one of our major challenges, and we are working on that. Collaborating with stakeholders. Most of the time, we go to communities with, pre-existing notions of, this is what we want to do. But I think de-learning the things that we already know is one of the first things if we want to work in the communities. And first hear from the local stakeholders around that. This has also changed in Nepal very much. I don't know if you're aware, but Nepal in the recent years is a heavily decentralized country with a lot of authority in the local governments. So we have drastically changed our our approaches in the communities. Um, Communicating the approaches, it is very difficult to communicate the integrated approach. If we go and talk only about agriculture, it's very easy to explain. If we go and talk only about health, very easy. Only about water, very easy. But when you're talking about this comprehensive approach, it's very difficult for people to grasp that, because that it's not very intuitive. So I think we need to work quite a bit on that, like how we make this integrated approach as a default mode of community development. Interdisciplinarity, it's a buzzword. We say, we have to work together across disciplines, but it's very, very complex, because we speak different languages. People from different professions, we speak different languages, we have different approaches. So spending a lot of formative and preparatory works early on is very important, and we have to be aware that there will be lots of inefficiencies. I would say inefficiencies and difficulties. But if we continue to persevere, we can really get the things done. I had lots of questions raised to me when we launched the microfinance program, and people asked, like, what do you know about microfinance? What do you know about financial handling? But then we got some people who are engaged in that on board and did that. So, whatever the difficulties, I think we really have been taking the lead in this, and we're very proud to see how far we have come, from a work that started with a couple of $100 with some microfinance programs. And my major message is, as one individual, as one institution, we might not change the world, we might not change the country or even the community, but at least if we can create even small successful models, then people will take that as a stepping stone to go further. So that has been our institutional approach so far. We want to do things in a small scale but very nicely, and then expand it. So with this, I conclude my presentation, and this is a favorite quote I have from Paul Farmer, the legendary global health person. Every night when I go to bed, I worry about how I will fulfill all the promises I have made. And every morning when I wake up, I think I haven't made enough promises. So I think this holds very well to most of us who work in the communities. Thank you.